Yeah, okay. So today we'll talk on templating of the hip, but templating is a part of the planning of the hip, and I will also be talking something more than the templating about planning as well. We know that failure to plan is planning to fail, and why do we require templating? We need to place the acetabular components in optimum inclination and version. This is to restore the normal kinematics, and this is also related to the long-term survival of the hip. You have to place the femoral component at the correct level and restore the horizontal and vertical offsets. And this is to prevent the dislocation and have impingement-free range of the motion. We also need to restore the limb lengths and prevent any limb length discrepancy, because we all know that limb length discrepancy is a principal reason or a major reason for medical legal suits in US. And if the limb is lengthened, we will leave an unhappy patient. We can predict the sizes of the components when we template. We can avoid the complications due to oversizing. For example, if you size a particular size of the cup in the acetabulum and suddenly you think that a very large cup is going, that means you may have fractured the column or you have reamed. Similar thing can happen in the femur as well. If you have doing an uncemented stem and suddenly larger and larger sizes are going in the femoral canal, you may have fractured the femur. So this intra-op complication can be prevented if you template it regularly. And all the new comers in the orthoplasty should template it. In fact, it is helpful for even the senior orthoplasty surgeons as well. We can arrange for the inventory, because in case you have abnormal morphology, the unusual sizes or the other implant inventory is not kept regularly, so you can anticipate this problem and you can have you can arrange for this thing. You can also plan the approach if it's a difficult approach. For example, if it's a significant trochanter is overriding and trochanter is not allowing a straight approach to the or access to the medullary canal, you may have to do a trochanteric osteotomy. So this can be anticipated on templating. So usually it is done on the acetabular side for inclination and the size, and for the femur it is for the size, level of the resection, size of the stem, and horizontal and vertical offset. So the versions for the acetabulum and the femoral cannot be templated, but I will tell you something in the planning how we can plan this or how we can anticipate this. So as a part of the planning, as regards the version, we need to see the sacropelvic mobility. So you need to take a lateral X-ray of the spine in sitting and in standing, especially in cases where you anticipate stiff spines in ankylosing spondylitis or where your spinal fusions have been done. For example, take this case for an example, an extreme case where there is an ankylosing spondylitis and the spine is fused. There is no spinopelvic mobility, and if you do the hip, you can see that the hip can dislocate. So if you have a nice software there and you can download it, it's known as Safe THA. So once you download it on the screen, you have to accept, and then there are four things which will appear on this app. So we have planned inclination, planned anteversion, standing pelvic tilt, and sitting pelvic tilt. And when you put these values, you can calculate how much version you need to give. And I have put this randomly, and I will just show you how you can do this. Now, typically, we would like to keep the inclination at 40. We would like to keep the planned anteversion in 20. Now, let's assume that this is a case with the ankylosing spondylitis of fused, there is a spinal fusion, and the pelvic tilt doesn't change on standing and sitting positions. So it is 40 degree in standing and in sitting. What does this mean? It means that it's a stiff spine. So once you click on this, it will show that you need to, even you intend to have this antiversion 20, but you need to decrease this antiversion because it will tell you the reason. Standing antiversion is too high, which may lead to impingement. What does it mean? If antiversion is too high, there will be posterior impingement and the hip will dislocate anteriorly. So from sitting to standing, hip may dislocate. So you have to decrease the antiversion. So this is what you can do a planning. It's not a templating, but it is a part of the planning. So this you can do. And it will tell you the reasons why you would do this thing in particular. There are types of templating. The typically what we do is on a conventional X-ray, and it is known as acetate templating. That means conventional X-ray, and we have templates which we overlay on this template. The standard or conventional X-rays, these are acetate templating. Then we have digital X-rays, and we lay the plastic templates over it. The third thing is digital templating software, which we have, they are available. And these are known as TraumaCAD software. This is one of the several softwares which are available. And third thing is CT scan templating. So most common thing is acetate templating, that is on the conventional X-rays. So this is more, in fact, more accurate. Acetate templating on the digital X-ray imaging is more accurate than the computer-based templating. Okay. Digital templating, that is digital X-rays and done on the computer, is less accurate. It is slightly more accurate for the cemented cups and stems, but less accurate for the uncemented stems. Besides the pelvis with both hips, which the X-ray, we need another set of X-rays as well. So one standard X-ray is pelvis with both hips, and we need to take femurs till the end of the stem, and this should be centered on the pubic symphysis. Then we need to take a lateral X-ray of the hip in standing and standing and in sitting position. In case you anticipate any problem, especially if there is any degenerative spine, then a lateral X-ray of the femur to see the bow of the femur, because if there is an excessive bow, then you may perforate the femur. Usually bow starts at around 20 centimeters distal, so usual stem length is around 13 centimeters. So usually this should not give any problem, but in case there are the stems, the femora are excessively bowed, then you need to know this in advance. Then you need to have these X-rays in proper rotation. External rotation will not in external rotation, but around 15 to 20 degree of internal rotation. If there is excessive internal rotation or external rotation, you will not know the exact the horizontal offset, and you will underestimate the neck length. Okay, so it needs to be in 15 to 20 degree internal rotation. And how do we know that? If your lesser trochanter is excessively prominent, then it is an external rotation. It is not there, then it's excessive internal rotation. It's just there, that means it's in a right rotation. Okay, so if it is in 15 to 20 degree internal rotation, this is how it will see. You will see it in axial section. You see that, and you can know the correct neck length. Whereas if it's a neutral rotation or in excess internal rotation, you will underestimate the neck length. Again, if the magnification, when you are taking a conventional X-ray, 40 inches is around 1 meter. So magnification, if you have bucket tray, that means you put in a cassette directly underneath the patient's hip, then the magnification would be around 10%. Okay, but there is what is known as a bucket tray. Bucket tray means you have a table there, and then the cassette goes underneath the table in a tray. So there the cassette is slightly away from the body, and the magnification is more, 15 to 20%. So this you need to know, because the templates are available. Usually they come in 1.5 to 1.2 times the magnification. So if your magnification is wrong, your templating can go wrong. And there is a Muller's formula. You can keep a calibration marker there, so you know how much magnification is there, and suppose A is the actual object and B is the cassette. So the magnification factor is A upon B, and it is decided by the distance of the film from the source, radiology source. That is D upon C plus D. So that's the formula. That's the Muller's formula. We mentioned this internal rotation brings the femur in the plane, and you can know the right neck length. Okay, but there are usually in the arthritic hips there is an external rotation deformity. So what do? Then you turn the patient in that much amount of rotation, and then take a lateral X-ray. You can do that. In case patient has flexion deformity of the hip and the knee, you can keep the position the patient like this on the table and take the X-ray. So acetabular, you want to know the depth, that is medial lateral position, the height, superior inferior position, and angular placement, that is inclination. Version cannot be calculated on this templating. So for example, a case like this, and neck shaft angle on the normal side is you can calculate, and you see the appearance of the lesser trochanter on the both the sides. That will tell you if the rotation is okay or not. Otherwise, you can go wrong. For example, case like this, this femur on the right side appears to be like a lateral X-ray. So there is an excessive rotational deformity. There is lesser trochanter is prominent. That means there is an external rotation deformity. Okay, so here you need to take X-ray in proper rotation, as I told you, to turn the patient. Otherwise, your templating can go wrong. Okay, then you draw the teardrop, and then you can see that you need to keep the, when you are, why do you need to see that? You compare this on the opposite side, left side. Okay, and on the right side, there is floor osteophyte. So you cannot place the cup on the osteophyte. Okay, you need to ream it deeper medially to put it as medial as possible. The cup should not be on the floor osteophyte. And when you do that, you get this sort of a picture. So this is a teardrop and is around 5 millimeter away from the teardrop. And this is how you restore the normal sort of a kinematics. Okay. So then you, on the X-ray, you also see the canal morphology, and canal morphology is typically divided into type A, type B, and type C. So if you take a distance 3 centimeters from the lesser trochanter, and then 10 centimeters, and take this ratio of X upon Y, then if it is less than 0.5, that means a narrow canal. Typically, this is in young patient with a strong bone, thick cortices, and these are ideal for the uncemented prosthesis. Then you have type B canal, where it is the ratio is between 0.5 to 0.75, and you can either use cemented or uncemented prosthesis. This is for planning. And type C is ratio is more than 0.75, and you can have scope pipe canal, which is typically like this, where it is an osteoporotic bone, thinner cortices, and if you put in a uncemented stem which is oversized, then you can have, sometimes you can have fracture. So this is typically suited for a cemented prosthesis. So this planning you can do it, and there are various indices which are available. You can use one of these. You can use either the previous one, or Calcar to canal ratio, or cortical index, or canal flare index. So these are various types of indices. Then you draw a line which is biaxial line. Now on the affected side, this is at a higher level, that suggests there is an adduction deformity. If the the pelvis appears like an inlet view, then there is a flexion deformity. Then you also see the distance of the the tip of the sacrum, the tip of the coccyx to the symphysis, and you see if it is normal or excessive. That will tell you whether there is a pelvic tilt or not. So all these need to be studied in the X-ray. Then you draw a teardrop, and you draw an inter-teardrop line. Next is you take a best fit circle as a femoral head, and then draw the center of it, which is, and from here you draw the line to the top of the trochanter. This is called LCD, that is lesser trochanter to the lesser trochanter, the center distance, LCD. L for lesser trochanter, C is center and distance. So this represents the vertical offset of the patient, and you need to represent, you need to normalize this or equate it to the normal hip. If the opposite hip is normal, then you have to make it equal to the opposite hip. This will also represent the true limb length discrepancy. Okay, so LCD difference will also represent true limb length discrepancy, which you need to correct at the time of the total hip replacement. You should not correct the apparent limb length discrepancy, because if you correct that, the apparent limb length is because of the adduction or abduction deformity, which is going to get corrected over a period of time, and you correct it by prosthesis alignment, then there will be, over a period of time, there will be in fact a limb length discrepancy. Okay, so now you join a line, then you join a horizontal line, or you can a horizontal line, and this is the angle of the deformity, that is the adduction deformity, and this distance is actually a apparent limb length discrepancy, which you should not correct, you should not bother, because this adduction deformity is going to get corrected after the total hip replacement. So you should not bother about that. You should correct the vertical offset, which will take care of your true limb length discrepancy. Then you draw anatomical axis and distance from the anatomical axis to the center of the head, that is the horizontal offset of the femur, which you again you want to replicate in the prosthesis. Okay, though this is the horizontal offset, in while we are operating, we don't know the anatomical axis, and we measure it from the tip of the greater trochanter to the center. So when you measure this before cutting the neck, you try and make it equal after the prosthesis replacement is done. Okay, we don't take it from the excuse me, don't take it from the anatomical axis, but take it from the tip of the trochanter while we are operating. Again, beware of the rotation on the X-ray, because offset calculation, especially the horizontal offset calculation, can go wrong if your rotation is wrong. You have Muller's templates which are available, and you can measure these offsets. Okay. Then acetabular inclination and position. So you draw a inter-teardrop line, and you take a 0.5 meter away from it. You take a point on the top of it, top of the acetabulum, and join these 2 points. So this will represent your position of the acetabular cup, and the diameter of this will represent the cup size. Okay, this is a rough guide, because the true size of the acetabulum can best be measured on the lateral X-ray. And center, okay, center of this will represent the center of the hip, which you are going to replace. Okay, so that is the center of rotation of the hip. Okay, though on the templating you would like to have a shoot through lateral, and lateral X-ray will better tell you the size of the cup than the pelvic AP X-ray. Then the site of the resection of the neck can also be calculated, whether if it is a large offset or small offset, and this will matter if your prosthesis is a collared prosthesis. So if it's a larger offset, then you typically you would take a low cut, sink the prosthesis down, and then put in a larger head so as to match the native anatomy or horizontal offset. Vice versa, if you have a small offset, because the prosthesis offset is fixed, whereas there is large variability in the anatomy of individual patients' horizontal offset. So if you have small offset, you would keep the prosthesis proud, you will take a high neck cut and put in a smaller head, or smaller head means not in the diameter, smaller neck of the head comes in +0, -5, +5 mm. So you can put, instead of 0 you can put in minus here you can put +5. So that is the way, small, that way you can cheat if you have fixed offset stems, and this you can plan on the templating. Now there is a concept of global offset. So previously we used to concentrate only on the femoral offset. Okay, the femoral offset is from the center of the femoral head to the anatomical axis. But it's not just the femoral offset which is important, but it's a global offset. So what is global offset? It's a femoral offset plus cup offset. That means cup offset is from the center of head to the teardrop. So what we usually do is Chanley taught us to medialize the cup. Okay, so you remedially and you uh, you slightly medialize the center of the acetabular cup. So this, the teardrop to the center of the hip represents the acetabular offset. So if you are medializing it, you need to increase the femoral offset in order to, simulate or equalize the native global offset. Otherwise, the native global offset will be reduced. And what is the consequence of the reduction of the reduction of the global offset? It is reduced more than 5 mm, then we have lesser abductor strength and decreased functional result, and these patients are usually not happy. So usually we medialize the hip, so you slightly increase the femoral offset. That will also give the stability of the hip, and it will also improve the abductor power. Then these templates are available. Usually these are cemented templates originally of the Chanley, and you can lay this against the conventional X-ray. So this is a conventional X-ray, and this is a Exeter hip. Now again, now the 44 is not the usual size which would be kept on the table. Usually the offset would be 30, 35, 30, 33, 37.5, but this offset, now you know that this patient has an excess offset, and you need to tell the company to keep this stem ready on the table. You typically align this center of this template to the anatomical axis, and this should leave around 3 to 4 for the cemented hip. This should leave around 3 to 4 mm of proximal cement and around 2 mm of cement distally. And you adjust the height of the cup, height of the stem or template in such a manner that it would correspond or align to the center of the native femoral head as far as possible. So that's how you would template it, and there are marks. So you can literally mark. Now this is a collarless prosthesis, so your neck resection would not matter as much as it would in had the stem been a collared one. But still, you need to know where your stem would sink or where your stem would be placed. Okay. On the uncemented, on the other side, on the other hand, you would slightly the select a stem which is slightly oversized. It would overlap the cortex, inner cortices to some extent, and that's the stem you would select. So if you select an undersized stem, then it is going to sink. So it should be scratch fit, and it should slightly overlap the inner cortices. That's the way you would select the prosthesis on templating. As regards accuracy and reproducibility of the templating, Muller said that on the femoral side is as high as 92%, and on the acetabular side in 90%. But more than that, more than 80% of the intraoperative difficulties were anticipated when you template. So that is more important. So there are no surprises on the table. Otherwise, you have surprises, and you have not kept the inventory on the table, and there is a problem. Other authors did not agree, and Carter thought that it was 50% accurate. Salvetti thought that it was 65% accurate for the uncemented prosthesis, for the femoral and for the acetabular. Magnification error as little as 6% is sufficient to cause an error in the calculation of the acetabular size. So acetabular size you may go wrong, but the femorals, on the femoral side, error at least 30% is required to cause one size error. That means on the femoral side, usually you are correct in sizing the femur as per Muller. Then there are advantages of pre-op planning. We discussed this in our previous slides. You can decide the type and size of the prosthesis. You can decide the correct position and orientation of the components. You can equalize the limb lengths and anticipate intra-op difficulties. And I will tell you how you can anticipate these difficulties. So you can restore the center of the rotation, restore the offset. You can have complete coverage of the acetabular component without damaging the subchondral bone. If the acetabular is not getting covered, you may require a flying buttress graft. superiorly, or you may have to use some other tactics, for example, take these X-rays, for example. These are unusual morphologies, or previously osteotomized, previously done varus osteotomy or so. And if you see a straight axis, if you draw a line along the anatomical axis, it crosses through the trochanter. That means if you take a usual entry through the neck, you will either perforate or you will go in uh, varus deformity. So this needs to be seen on the table. So in this, if you are to have a straight axis, you may require a trochanteric osteotomy so that you can get a straight access to the anatomical axis of this femur. Otherwise, you are going to perforate, or you are going to put the stem in varus. Take the another example. This is excessively neck shaft angle is excessive valgus around 155 degrees, and there is excessive anteversion of around 47 degrees. Now, with the usual stems which are tapered one, you cannot put it in retroversion, because the version, especially in the uncemented stems, the version is usually decided by the morphology of the canal. Now, these are the tapered stems, and I cannot put it in this manner. Okay, the blue one is in an antiverted position. I cannot put in excessive antiversion. The stem antiversion is decided by the morphology of the canal. Okay, so in uncemented, if you have abnormal morphology, then you need to plan or keep special modular stems where you can change the version. In cemented, you can change the version because there is a lot of space. Okay, so if you have excessive antiversion, you may require these sort of stems, and you can, the planning is as usual as you would do in any other case. You lay these templates there, and you can, these are SROM stems where you can rotate the neck almost 360 degrees and change the version on the table to suit the patient's native anatomy, or to have a version in such a manner that there will be impingement free motion. Or you can have this sort of stem which are non-modular but conical stems. There are two offsets, 125 and 135 degree, and you can literally rotate. If you can see the axial section here, you can literally rotate the stem in a way you want it. So you need to keep this, and you can anticipate this difficulty in a pre-op templating. Similarly, you need to take a lateral X-ray if there is an excessive femoral bow. As I told you, it starts at around 20 centimeters. But if you do not anticipate, it starts early. You do not anticipate, there is a reverse bow in the proximal femur, and if you do not anticipate it, you will in a cemented stem, you will touch the cortex at one position, and their cement mantle will be defective, and your prosthesis may not survive for a very long time. So this you need to anticipate. Again, the valgus osteotomy, previously done valgus osteotomy, and you try and template it, so it doesn't go. If it doesn't go, then you may require an extended trochanteric osteotomy, or you may have to redo the osteotomy here and align the canal again. So these are the things which you would know on the templating. And determining the level of the neck cut. Now, by and large, the standard X-rays would magnify. So they magnify, if you are taken at 1 meter distance, they would magnify 20%. For the obese patient, there will be further magnification, because from the bone to the cassette distance is still larger. Digital X-rays usually undersized, they will be at around 97%. So even usually what we do is we want to template the digital X-ray. Nowadays, there are no conventional X-rays, and we want to we want to template the digital X-rays, and we ask for the true size X-rays. So even if you do the true size X-rays, they cannot be templated. Why? Because the templates are available in 1.2 or 1.5 magnification. Okay, so when you ask for the digital X-ray, you have to tell the radiologist specifically that I want the X-ray magnified to 1.2 times magnification. Then you can truly use these templates on these X-rays. Then is another point, a subtle point, that the many times the original templates are always useful, because if you Xerox the templates, then again the magnification, the Xerox may not be in the same magnification, and then your calculation can go wrong. So ideally, better to use the original templates than the ones which are Xerox. Xeroxing, during the Xeroxing, the magnification can go haywire. So templating is the way to go. nowadays we have on-screen templating using specific softwares, and now we can have either computer navigation or robotic, which is more precise. I will give an example. Bilateral AVN, again this is a conventional X-ray, and you can after templating you get a perfect this thing perfect picture. Now Luvinek told us that you should have antiversion in 15 to plus and minus 10 degrees and abduction 40 plus and minus 10 degrees. But if you see, in spite of these, in spite of being perfect, that is in within the circle, the 3 out of 9 dislocations, that is 33%, occurred within the safe zone. That means even if you have it within the safe zones, you can still have the dislocation. Why does this occur? This usually occurs because of impingement, and this occurs because of the spinopelvic mobility. You have to identify the high risk factors for dislocation, and what are these? Spinal fusion at 3 or more levels. If there is no change in the sacral slope in sitting and standing, and these are the cases where you would require a dual mobility. You would rather select dual mobility cup, which has a higher jump distance and which will prevent from the impingement and dislocation. So this is what you would plan. It's not templating as per se, but it is a part of the planning that during the templating, if you see this, then you would rather select the prosthesis which is different from the conventional prosthesis. There is a small algorithm which I would like to tell you. If you have total hip replacement, sitting and standing position, you take AP view. AP, I already told you the templating. In lateral X-ray, then you see whether there are no risk factors, intermediate risk factors, or high risk factors. So there are no risk factors. You can go ahead very well do a conventional implant, and there is no problem. If you are intermediate, what are the intermediate risk factors? Spinal fusion to the S1, spinal fusion of 1 or 2 levels, aged patient more than 75, female patient, THA done for hip fracture or post-traumatic etiology, or there are other neurologic comorbidities, or high activity level. This, if you find one intermediate risk factor, then you can do a conventional X-ray. But if you find 2 or more risk factors of this intermediate risk factor, you should select dual mobility. Again, there is a high risk factor column where you have spinal fusions more than 3 or more level, and no change or increase in sacral slope between standing and sitting, then you should select a dual mobility. That's the advantage of planning. I am coming to an end of the talk. I would like to mention there is a concept of anti-inclination. That is, you would see it's between takes into account the antiversion as well as inclination in the lateral X-ray of the pelvis. So usually there is a change of sagittal position of the cup as pelvic tilts. Now what Luvinek and what we used to consider in the past was a static antiversion, but antiversion doesn't remain static. It changes during the sitting and during standing and during sleeping. Usually it increases when person is sitting and it decreases when person is standing. So if this doesn't occur, then there is going to be impingement. Usually this anti-inclination in standing, this is the anti-inclination in standing would be less, and it would be more to accommodate flexion of the hip in sitting. Okay. Or the pelvic slope, this is a pelvic slope, so in standing it would be more. This is a pelvic slope, it is around 40 degrees and less in 20 degrees. So if this is not occurring, then the hip may impinge either anteriorly or posteriorly, and it will dislocate from sitting to standing position or vice versa. So this you need to understand. This is for these are the current concepts, and perhaps I may have confused you more. So if you are confused, I am open to the questions. Yeah, thank you.